Hi, and welcome to this presentation on the AHRQ Knowledge Transfer Framework. My name is Scott, and I want to explore some background as to why such a model is needed. Research is only a beginning and not an end in itself. This quote by Agency for Healthcare Research and Quality Director Carolyn Clancy provides insight into a pervasive problem in healthcare, the slow translation of research evidence into practice. Vast silos of knowledge have been discovered, yet much of it is unknown to the end users, the individuals who assess patients and provide them with life-saving treatments. As a result, patients suffer needlessly. AHRQ states that it takes an average of 17 years for only 14% of original research findings to be utilized for the benefit of patients. There are multiple reasons for this slow translation to practice. Individual practitioners cannot effectively wade through this ocean of knowledge on their own. Furthermore, healthcare settings often strive for streamlined efficiency and are reluctant to invest in the long-term challenge of implementing change driven by new evidence, resulting in an environment that is inhospitable to receiving new knowledge. Regardless, this slow pace is unacceptable. We as healthcare professionals owe it to ourselves and most importantly to our patients to do better. AHRQ has developed the Knowledge Transfer Framework to facilitate more rapid and complete integration of new knowledge into clinical practice. Traditionally, knowledge has been pushed at healthcare professionals. The Knowledge Transfer Framework combines this with a more effective information pull from end users of knowledge by facilitating dialogue between researchers and representatives of frontline healthcare workers. The framework specifies 3 stages of the knowledge transfer process: knowledge creation and distillation, diffusion and dissemination, and lastly, organizational adoption and implementation of the discovered knowledge. Let's look at these steps in detail. The first step in the model, knowledge creation and distillation, is to discover new knowledge through research. The knowledge distillation process involves evaluating and prioritizing the knowledge to be disseminated. It emphasizes findings that are most important and most actionable, increasing the likelihood of adoption of that knowledge into practice. The second step is diffusion and dissemination. Crucial to the success of this step is to form appropriate partnerships between researchers and intermediate sources such as healthcare organizations that can form a reliable and credible connection to the healthcare professionals. This eliminates the unrealistic expectation that individual practitioners interrupt their work to wade through the vast ocean of evidence on their own. In this way, the AHRQ method extends beyond the traditional and often ineffective information push method. Lastly, in organizational adoption and implementation, knowledge must be used to develop new interventions within an organization. A change champion is a point person within an organization charged with helping overcome barriers to knowledge acquisition. This person might identify more robust training, change processes that inhibit adoption of new knowledge, and publicize the benefits of change within the organization. Eventually, change inspired by new knowledge will alleviate the problem that the knowledge was supposed to address, creating its own momentum and sustainability. At this stage, the innovation can be incorporated into the structure of the organization. Now, the knowledge forming the new innovation has become a lasting standard within the organization. In this way, the AHRQ Knowledge Transfer Framework propels the translation of science into service.
Hey guys, my name's Casey, and I'm going to talk to you about the strengths and weaknesses of this framework. Starting off with strengths, there are different types of research and different organizational needs that when we're trying to combine these two, it requires a tailored approach. So the AHRQ framework is a structured format, but it does allow for a multifaceted or fluid-like approach that can be individualized to the end user. It is written in a linear or phase-like fashion. However, according to AHRQ, it does not need to be performed in a step-like manner. Different phases or actions can be done simultaneously and or in different sequence if need be. Information push is the traditional form of knowledge transfer, kind of like a salesman pushing a product on a consumer. The AHRQ framework implements a information pull element, which is mainly achieved through intermediary teams, allowing open communication between end users and researchers, allowing more comfortability on the end user side to ask about evidence-based practice available to them. The distillation process is probably the biggest strength of this framework as a whole. There are nearly 2 million articles available to clinicians every single year, which can be very overwhelming and cumbersome and is a well-known barrier to knowledge transfer. The distillation process aims to eliminate this barrier by developing partnerships that identify research which is more applicable or actionable at the clinical level. Looking at weaknesses, it is a framework that can be individualized. However, the broad nature of it does leave room for misinterpretation and can be viewed as too much or information overload, especially if someone more novice in evidence-based practice or organizational processes is trying to implement it. It relies heavily on new linkages, such as the multidisciplinary knowledge transfer team, which sits at the middle and links researcher to end user. If this team is not formed properly and communication falters, it can lead to a middleman or telephone-like downfall to the initiative. There are changes that are required at organizational levels. When we are looking at the multidisciplinary team, organizations involved in that team may need to broaden their mission or scope in order to fully embrace the framework and allow it to be successful. If we are looking at end users or the facilities in which the evidence-based practice is trying to be implemented, the facility itself needs to have a practice culture that supports and encourages action and change. Without these values being present at the facility or organizational levels, it can lead to backsliding or slippage, which ultimately can lead to a downfall of the initiative or framework and ending of the progress made by previous steps and stakeholders.
In our study, Stage 1A, a PICO question was created. In surgical patients undergoing general anesthesia, does BIS monitor use compared to standard practice improve post-operative recovery times? Information was searched on databases such as CINAHL and PubMed. For Stage 1B, educational materials, guidelines, and study results can be given to providers to provide more relevant information. For Stage 2A, different partnerships can be made to increase awareness of the research findings. For this study, different partnerships can be made with professional anesthesia organizations, professional conferences, or even hospital groups. For Stage 2B and C, information can be distributed to both the masses and the target audience, which in this case is anesthesia providers. This can be through posters, emails, or presentations. For Stage 3A and B, implementation can be started through hospital-wide policies, quality improvement initiatives being started, or individual providers following recommendations into their practice. For Stage 3C and D, implementations can be confirmed through permanent policies in hospitals, widespread acceptance by providers, and improved outcomes for the patients. This study showed how this model was used for the creation and implementation of a pocket guide given to specifically nurses serving under military operations. For Stage 1A, research was completed by military nurse scientists, and information was gathered through individual research, military conferences, and content from the Joint Trauma System. For Stage 1B, all evidence in the guide was reviewed by experts in the Tri-Service Nursing Research Program, which had 4 specific criteria to prove its relevancy to the situation. For Stage 2A, the Tri-Service Research Nursing Program supported the creation and implementation of the Pocket Guide, while arrangements with military organizations were created. Tens of thousands of copies of the Pocket Guide were distributed to the military members. This included both hard copies and ebooks to increase the total numbers of copies given, while additional guides were specifically given to the military nurses, which were the target audience. For Stage 3A and B of implementation, key components of the Pocket Guide have been recommended and used by military nurses, and in Stage 3C and D, these have been permanently put into guidelines in military practices. Examples of this are for pain management, burn resuscitation, traumatic brain injuries, and safe patient handoff.